Good morning, everyone. Is this on? Yeah. All right, I got the thumbs up from the back room there. Awesome. Good morning, everyone. Welcome to Grand Rounds. It's our pleasure to have Dr. Jason Hall here as our annual visiting colorectal professor. We had a nice afternoon yesterday with case presentations with residents and fellows. So we got some good advice and education on different topics. And then a nice dinner at Waterman Grill for the Rhode Island chapter of the American College of Surgeons. It was well attended. Thank you for everybody that was able to make it. And so we're just happy to have Dr. Hall here. He's been around New England for a long time. We've sort of met in our early careers in the early 2000s. And Dr. Hall's started his undergraduate at Holy Cross in Worcester, and then was at Harvard for medical school and Masters of Public Health, and then stayed on in Boston and Mass General for residency, and then at Leahy Clinic for colorectal fellowship, where he stayed on as faculty, and then eventually got to be program director and taught many years of colorectal fellows. So we got to know each other pretty well over the years, and it's been a pleasure working with him. And then after time there at Leahy, went on to be the chief of colorectal surgery at Boston Medical Center for a number of years, and then now is a surgeon in chief at the Tufts Medical Center in Boston. So happy to have him here. Thanks for joining us, and I look forward to an interesting talk. Great.
Good morning. All right, people are awake. I want to thank Adam and Steve for this kind invitation. It's been my pleasure to be associated with these gentlemen since I've done my colorectal fellowship, and the fellows who I got to spend some time with yesterday really have joined a fantastic family. Like the colorectal surgery community nationwide and especially in New England is really fantastic, and especially Steve has been a great mentor to me for 20 years. And it's kind of surreal coming to his place to talk about these kind of topics. So thank you for having me. So you heard my talk on a clinical topic last night, or some of you did. Today, this is kind of more a thought experiment, right? So it's something for us to think about together, and I'm interested in your feedback about how we respond to uncertainty and change, right? Because this is really what we all have to face, right? And so I have to face it. The people I report to have to face it. The people that report to me have to face it, right? And our success, I think, as a medical system, nationwide, depends on how we start to think about these kinds of topics, and in our relationship to change. So I was a chemistry major, very kind of entrenched in physics and chemistry, are familiar with the Heisenberg uncertainty principle, right? That it's impossible to know the momentum and the position of a particle at the same time, right? Either you can know a lot about the momentum and not so much about the position, or a lot about the position and not so much about the momentum. Everybody familiar with that? Does it sound vaguely correct? Well, I kind of feel like that's a life in surgery too, right? Like there's only so many things you can know and so many things you can control. And we live in an uncertain world. I don't need to sort of detail all the things going on in the news. You guys watch it just like I do. A lot of stuff going on. But as we dive into healthcare, healthcare in 2026 is complex. And the the main theme is that the margins that some of our foremothers and forefathers enjoyed are not as big, right? There's not as much money around. It's harder to do the business of medicine. This is current hospital expenses as of 2022 at some of the major hospital systems in the United States. So the orange is the expenses, the blue is the revenue. Right, and you can see in most of the cases, except for the Sutter place, must be it's in California, but I don't know what they're doing right, but most of the places, the expenses far exceed the operating revenue. Dr. Pryor is looking at me with a knowing eye. Up to somewhere around 40% of hospitals last year were operating at a loss. This is another nice chart from JAMA. I want you to focus on the orange dots, which are non-profit hospitals and their operating margins, right? So in metropolitan areas, there, most of them were somewhere around like a 3 to 5% operating margin. In smaller metro areas, less. And in rural areas, some years, no margin. A little better in 2020. And in New England, we've been through our share of change, and frankly, with the sewer system chaos, right? There's been a lot of change with a lot of the health systems in our area undergoing structural and financial change. So this has led to, there's been a phenomenon of providers leaving the workforce, and every time this happens, it's quite an expense to the system because we have to replace and retrain. And much of that has been attributed to burnout, right? So like the concept that everything is changing so fast to have a lack of autonomy. And it eventually becomes overwhelming such that people choose to choose to leave. What's interesting to me when I dig into this topic, though, this has been a phenomenon for 30 or 40 years. Like when you measure burnout in surgeons, it's been pretty substantial that 30 to 40% of surgeons report burnout for about 30 to 40 years. It's higher in other disciplines like anesthesia, but it's never been zero. And so, and as a matter of fact, some studies show that it's actually getting better. So that's something that we should talk about as we move um, further on in the talk. But these are some of the contributors to that burnout. So shortages. We were talking about the importance of the CPD just before we started the talk, right? So like, I need my clean instruments. Where is it? Where are my resources to do the job I need to do? Man, my call requirements are really excessive. Like I take too much call. Many of us are in dual physician relationships, right? So I always feel like, oh man, I'm on call this weekend, and then the next weekend my wife's on call. So I'm always on call, right? Right. And so that's a definite thing that we're seeing. All of over the past 3 to 4 years, like my faculty, they're like, he's the productivity king. They feel like that's all I talk about, right? And many of you have probably experienced that, where there's a lot more emphasis on like, what are you doing with every hour of the time that you are here in the hospital? And then there's all these other non-clinical requirements, right? So you guys lock in and there's some e-learning thing. that you have to do, right? And you like a course that you have to do on top to stay up to snuff with the hospital requirements. So all of these are contributors to this overall sense that there's less autonomy, less control, less agency over how your career is going and how you can deliver care to patients. So the American College of Surgeons has said this. Um, Meaningful improvement will require interventions to remove and mitigate organizational and system level drivers of surgeon burnout. So my personal belief is that as physicians, we need to work on understanding agency, understanding our environment, and figuring out ways that we can be effective advocates for change. And what I'm going to show you is that change management is not going to administration and just railing against them, right? Or saying like, look, I just need this. It's really a discipline, right? It has certain characteristics and steps. There's a science behind it. And the more that we embrace that we get educated on that, the more effective we will be in advocating for the changes that we need to see in our workforce. There are many ways to sort of get this kind of education. This is just a small sampling of leadership books that you can buy at your local Barnes and Nobles if it's still open. But all of them try to define one thing. And so, what is a leader? And somebody put up a nice, somebody reported on, who's the doc that reported on the ACS leadership conference last night? Dr. Kwan, right? And he talked about this concept of leadership. Often as people grow as leaders, they become more interested in the growth of others and taking a group of people towards a common goal rather than their own personal interests. He had a great graph. I wish I could steal that from my talk, but so that's leadership. And great leaders often ask why instead of what, right? So they're not thinking like, well, look, I want to be chair of surgery or CMO or division chief. They're thinking, what is it that I want to accomplish, right? Like what's the end goal and how can the position help me make that change within the organization? Like, I want to innovate a new treatment for IBD, right? What's the position that's going to help me do that, right? Is it division chief? Maybe not. Maybe I want to be head of the research foundation, right? So it's important to think about this side first, right? As you start to plan your personal goals. So what I want to review today is some of the intellectual work that's been done on change management. I've chosen Cotter. Cotter was a professor at the Harvard Business School, and he wrote an important paper in 1995, Leading Change, Why Transformation Efforts Fail. And he outlined this process for leading change in complex situations. Now, I am going to show you a fairly granular example of some of the work I do every day, and it's going to seem like really simple. You're like, why are you showing me this? But the idea is simple things require a lot of thought and a lot of process management to change the smallest thing, right? And sometimes I think as physicians, especially as surgeons, we can go in and we can have an effect immediately, right? Somebody's has peritonitis and we go in, we resect the piece of bowel and they're better, right? And we're like, that's the way everything should work, right? But complex matrix organizations, by definition, do not work that way. And so for, you know, what I tell my young folks is for leadership and change management, patience is an attribute that you need to cultivate, right? And you need to really scale down what you're trying to achieve in order to be successful. So Cotter has been criticized because he didn't really do any research when he wrote this paper. He just thought these were good ideas. So also take it with a grain of salt. I think it's proven itself over time, but that's one of the big criticisms of this work. So he said, look, you gotta identify what the problem is, establish a sense of urgency, um, form a powerful coalition, create a vision, communicate the vision, empower others to act, create short-term wins, consolidate gains, and institutionalize the new approaches to what you're doing. So let's start with an example of a hypothetical chair of surgery who just started, and the senior leadership says to you, like, well, what's going on with the OR? Because only like 30% of the rooms start on time. Quality is good. The morale of the people working there is low. They say, look, this place, we can't do anything right. Like we know we provide good care, but things don't seem to be working. And by the way, you find people are so overworked that the OR nurses are not getting breaks and they're quitting, right? They're saying it's too much to work here, right? So hypothetical situation. So, there you are, 39%. Rooms are not starting on time. So establish a sense of urgency. So one of the things looking at this was, do we have enough people to start all the rooms every day? Right? And so one of the things we thought about to create that sense of urgency was to close some rooms, right? And you can imagine what that conversation was like with leadership, right? Because they're like, wait, we brought you here to grow rooms, not close rooms, right? But the point to them is, like, if you don't have enough people to sterilize the instruments or run the rooms, you're going to have less people tomorrow, right? And so that's what Cotter means by establishing a sense of urgency. What is it we're really talking about, right? Because people can start to spin and go in circles and like, whose fault is it? But what we're really talking about is a staffing issue, right? We don't have enough staff, right? And so establish a sense of urgency. And that brings up an important principle about the difference between management and leadership, right? Because you are going to, as a physician, you're going to be working with an administrative staff who are of largely managers, but somebody has to provide leadership, right? So management is really the idea that you want to maintain the status quo and minimize risk, right? But for many of these situations, what's really required is leadership. What is the vision? Where do we need to get to? And there has to be some courageous decision in there. Somebody has to put their foot out or their head out on the line to make sure that there's an effective change to move the organization in the correct position. And so when you establish the idea that, look, this is a burning platform, you make it such that the status quo is no longer acceptable, right? And if we stay here, we're going to fail. So for Cotter's first principle. Second idea is you cannot do this alone, right? So was I going to march out there and be like, this is, we're changing everything. Jason just said to do it. No, right? So you gotta involve anesthesia, nursing, OR administration management. And one of the things I found was I said, look, who is governing this process, right? Is there an OR exec committee? And I said, well, we used to have one, but it hadn't met in 18 months after COVID. It kind of fell apart. OR exec committee, right? Get the division chiefs, mid-level surgeons, people who are really doing a lot, driving a lot of the clinical activity into the room to tell us what's wrong, to inform the process, to tell us how we could do better. And that became like a religious weekly kind of event where we could really start to understand what the issues were and start to change them bit by bit. And also give the impression to people that they were being listened to and things were being acted on, right? And so that was an important maneuver. And then the surgical quality committee, right? Having people understand with some basic metrics that they were doing a great job, right? That they were providing all of this great care, and for the most part, people were having excellent results, right? And the big complications that we know that we all have and are going to continue to have are the minority of what we do, but the majority of what we do is actually really high level care, right? So starting to be able to communicate that back to folks. So some of the ideas um, that became important as you start to bring a big group like that together are this idea of psychological safety. So you want to foster an environment where every team member from the doc to the tech and the CPD can voice a concern without fear of retribution or without feeling like they're not listened to. Um, uh, Developing a tight culture, meaning, listen, if we said we're going to do this thing, we're going to do it, right? And we're going to have an accountable person who is going to report back on whether we fulfilled that or not. And if it's okay if we weren't able to do it, but let's at least understand why we were not able to. Interdisciplinary collaboration, I've already talked about that a little bit. And then something that I'm still working on is recognition and continuous improvement. So how do we not only make people accountable, but recognize them when they did a great job, right? And that encourages them to do more and to further own their workplace. So part of the work we did was, well, what's our vision? And this is what our vision statement looked like. Some flowery language, but really did, I think, turn into a real way in which we operated. As we started to create the vision, that broader statement of what we wanted needed to turn into like some real metrics. And these are some of the thoughts that people had. So turnover time, surgical volume, all of these things. And so I said, well, look, you can't do all of those things all at once, or you can, but you really have to concentrate on a couple. So what we focused on is surgical volume and on-time starts. And uh and that allowed us to really kind of focus in on sort of what we wanted to do and where we wanted to really focus a lot of our efforts. So this is what the trajectory looked like. It turned out when we really measured the number of first case on time starts, it was lower than 39%, it was 30. So that was distressing. But this is where we ended up last year. And then I will show you at the end where we maintained this year. Um, So one of the first things we did was staggered starts, right? Because we had cut, like, so many people had left, right? And we cut the rooms down, but we still didn't have really quite enough people to start all the rooms at 7:30, right? So we said, well, what would it look like to start at 7:15, 8 o'clock and 7:30, right? To give the nurses some time to get the patients really prepared for surgery, right? Um, and so we decided that we would implement SOAP, which is a way of tracking when each member of the team was ready to go. So SOAP stands for surgeon, operating room, anesthesiologist, perioperative services, right? So this allows you to track when each one of those steps is ready to go. And so we could understand what the barriers were to getting into the room on time. So you can see, as soon as we were able to track that, and people knew they were accountable for a certain part of the process, there's a jump, right? Um, you can see after we announced, we had a little dip here. That was like the CPD COVID outbreak, right? So like 10 people got COVID and you couldn't turn over the instruments every night, right? So there are realities of, just operating a large institution where people get sick, right? And it really affects your ability to run the place efficiently. Um, After we did so, we started to see that there were some troubles with arrival times, right? So, um, which previously was, well, look, the room wasn't ready. Like they didn't have my stuff. But when you looked at the soap times, it was like, doctor, you weren't here to sign the patient in, to sign the consent or do do the attestation, right? Starting to be able to see that, pointed out that like we had some communication to do to feed back to people how they were contributing to the overall result. And so, oh, I need to go back here. Let's see. And so what we started to say is like, hey, can we have a process by which, for let's say for 7:15 case, we are going to have these preoperative things done by this time. Right? So everybody knew what time they needed to have their stuff done, such that we had enough time to get the patient into the room easily. So things were moving along, but not as quickly as certainly I wanted or others wanted. And this is where we had to have courageous conversations, right? Because we had made all this progress, but like we still weren't quite where we needed to be. And our leadership team came together and said, really, do you really want to change this? Right? And are you willing to do the things that it really takes to communicate to folks the importance of all of the things I laid out before, of being on time, of having the instruments ready, of all of those things. And we all came to the conclusion of yes, and that meant different roles for different members of the team. Um, and so that for me resulted in personalized feedback, right? So for nursing, it was personalized feedback too, right? Like if their stuff wasn't ready and we didn't know why, the director of perioperative services nursing had to communicate to her folks. I had to communicate to my folks um, in the form of a letter that said, hey, this is what soap showed us, right? If you go back to this previous slide. Um, uh, you were due to start at 7:40. Your paperwork was completed at 7:49, right? And you can imagine that this was very popular, right? Nobody likes getting the letter from Dr. Hall saying, hey, like we've got an issue here. But you see, it's not accusatory. It just says this is what the data shows. Please let me know if there's a way that we can help you to meet that metric and goal, because the overall goal is important to all of us. When we started to have those conversations as a leadership group, these were the themes that came up, right? So people had a fear of confrontation, right? Luckily, I don't have a fear of confrontation. That gets me into trouble all the time, but people had a fear of failing, right? People didn't want to disrupt the culture. They said, look, we've always been so nice. We've always had such a nice culture. Everybody's been always so kind. But sometimes it takes a little transparency, is what I would call it, to have an organization run well. And one of the ones that was really important was fear of not being supported. So one of the conversations I had with nursing was, they said, we're not sure you're going to support us when we start to really lean in on this. And so convincing folks that, no, we're all in this together, and to use the term the young people use, we're going to ride or die on this together, is what really got us to take action together. So do you guys know who said this? If you're not fearful, you're probably not changing enough. So um so once we sort of started getting this thing moving, and start to think about how do you lock down the change and how do you get more change? How do you start to capitalize on what you've achieved and start to take that to other areas? Um, so what that looked like was, well, what can we do to thank the faculty for moving from 30% to almost 80% of the room starting on time? And what we heard back was, hey, look, this is cool, me getting here on time, the room starting on time, but I also really hate it when I do a half an hour case and it takes 2 hours for me to start the next case, right? That's what we heard, right? And so that the next step became, well, what can we take from the first case on time start to tackle turnovers and other issues that the faculty really felt were way more important than the first case on time start. But what the first case on time start work did was it allowed us to have an organizational structure that could actually tackle issues, right? Before we didn't have that, right? And so we're just spinning, right? But by working on one thing, we developed the ability to work on multiple things. And so this is what this looked like. Cultural safety, site marking, utilization and onboarding for the robot, a big one for the faculty, specialty specific teams. It allowed us to shift cases from the main campus to multiple other locations where patients would be better served with more efficiency, bringing more of the bigger and long length of stay cases to the medical center. So a lot of other things came from this just by getting organized around like one goal. So it's a wonderful story. You guys are like, okay, so the rooms start on time now. there are also plenty of things that didn't work, right? And I'm not showing you those today. I'm showing you a thing that worked, right? But it's important to admit that like not all of these are going to be always successful. That doesn't mean that you can't, that you should stop trying. So what are the shortcomings and critiques of Cotter's work? Well, one thing about Cotter's work is it seems very linear, right? Like you create a vision and then you do this and then you empower people and all of a sudden you have success. And that's really, I've painted it that way. It didn't really happen that way, right? Many of these things happened at the same time, or we did something and it didn't quite work. We had to revise it and go back, right? So it's not as linear as it's presented. One thing I do think we paid a lot of attention to was power, politics, and cultural context, right? Like I told you, like about some of those courageous conversations we had, a lot of the themes there were actually like, what are the power dynamics within the OR and who has a say and who doesn't, who feels supported and who doesn't, right? And again, I think Cotter, by presenting this linear model, he underplays the difficulty of moving large groups of people. And if you have a lot of resistance, it can be impossible to move these kind of things because people will sabotage it in many different ways if they don't agree. They may not say it to you like, Jason, like this is a terrible idea, but they'll do subtle things to make it not work. And so it's really important to get their buy-in so that they really feel like they're part of the process. So the thing to think about as you're doing this kind of work is that even though Cotter says, well, you're going to go 1 through 8, be flexible and understand that strong leadership also has to be partnered with engagement, with getting folks really bought in and understanding like sometimes your ideas while they might be good, might be better served by just letting somebody else accomplish the same goal their way, right? Because now they're engaged in doing it in a way that's meaningful to them. So a couple other thoughts. We did a lot of work on building trust. This is often absent in many organizations. And one of the reasons is that people don't commit to excellence or can't sometimes is that they don't really trust people to deliver on what they said. They don't trust their colleagues to deliver on what they said. So that's a key point. When you're feeling discouraged, I have this up in my office. Peter Drucker said only 3 things happen naturally in organizations. So this is natural to big organizations, right? So you shouldn't feel like, oh, this is tough, this is MGH, we just can't do anything right. It happens in every big organization. Friction, confusion, and underperformance. You put a lot of people together, you're going to get those 3 things. Everything else requires you to lead, right? You have to diminish the friction, the confusion, and the underperformance. That's why you're there, right? So some general principles: clarity, clarity, clarity. Look for win-win solutions. And there's a lot of negativity out there. So I generally try to see the positive in the situation, even though I may be feeling negative on the inside. I'm like, let's focus on what's positive. You have to have some thick skin. You have to plan for success and failure and keep a long-term perspective. So this jumbled up a little bit, but I told you this fantastic story of how we got to 80%. And recently I had to report to the medical board on how we were doing. And actually without sending the letters, over the last 6 months, we've been able to stay at about the 70% range, right? Just by setting up that organizational structure. So, I was pleasantly surprised to see that, right? Because I had a lot of other burning platforms, and we made a conscious decision that, hey, like, you're not going to send the letters anymore. Let's just see what happens. And it maintained over time. So this is a celebration of us breaking the New England record for heart transplants last March. And none of that work could have been done without setting up an effective organizational structure in the OR. And so you see, like, all of this work is nitty gritty and boring and like culture and people, and like you're like, oh my God, but it has an effect on patients at the end of it, and that's what we're all here to do. So thank you for having me this morning, and I'm happy to answer any questions.
Thank you so much for that really good overview of leadership and
Yeah.
change management. And I think you really did a great job presenting how you as the surgical leader can lead change.
Yeah.
What words of advice do you have for the people who aren't yet in a leadership role, and how do they engage in change?
Yeah, I have another version of this talk that's a little bit longer, which focuses on medical students and residents. Because I didn't have any leadership training in medical school. I didn't really have it in residency. As a young faculty member, I did a couple of leadership programs, right? And that's where I started to clue into like, hey, like there's maybe a little bit of a science to this, right? Like leadership is not me walking up to the fishbowl and like banging on the glass and asking like why my case isn't going, right? Like it's more complicated than assertion, right? And so my belief is two things. You're all already leaders, right? But you need to think of yourself that way, right? And so an important thing to think about before you open your mouth to say anything is what is the situation and what would a leader do in this situation, right? So many of the faculty that I'm trying to talk out of some problem they've found themselves in has to do with not reflecting on that time, right? Viktor Frankl, right? We all have like what does he call it? He calls it a space between perception and action, right? Where we perceive something and oftentimes we don't react, but we have time and space to reflect on what we want to do and to analyze the situation and then do something effective, right? So that's a very important principle that you can start today, right? But I also think formal training for students and for residents should be part of what we're looking at a national level, right? Because it's only going to get more complex as the resources tighten, as we're, one of the complaints my faculty have is they say, well, look, I never have the same team. It's always a new group of people every day. I don't know who they are. And wouldn't it be good to learn how to marshal a team of people that you're just meeting for the first time that day, right? That's a skill that I think we kind of need to teach people how to do. So I think there's a lot of reading you can do on this. There's some things you can start today. I think we should have a broader mission as a surgical community to start to train people on some of these techniques more broadly and across the board, maybe like the Association of Program Directors, and probably making it part of medical school training, just some basics in leadership and change management.
Thank you.
Yes, sir.
I loved your talk.
Thank you.
This has to do with change and keeping a team together in a complex system.
Yeah.
And I think I got a hunch of the answer, but.
Yeah.
For our letters, for surgeons for being late.
Yeah.
In my role, I had two examples where actually the surgeon did the right thing by marking late. But got criticized.
Yeah.
And then came to me like, what the hell?
Yeah.
One is site marking was there 20 minutes early.
Yeah.
And the patient identified a different site.
Yeah.
Than the consent.
Yeah.
Proper picture set.
Yeah.
Okay.
Yeah.
Epic hadn't downloaded the things.
Yeah.
Ran to the office.
Yeah.
Got the
Yeah.
appropriate thing, came back and signed 5 minute time late, but they still started on time.
Yeah.
Got a letter. Did the right thing, culture, safety. This was actually a huge one, should have been celebrated.
Mhm.
Another, the surgeon signed like 3 minutes late,
Mm.
still started on time. Signed it late because one of the colleagues was yelling at one of the pre-operative
Oh,
nurses
jeez.
and appropriately said, I'm gonna back off here.
Yeah.
I would say did a great thing for retention.
Yeah.
Still got the letter, comes, what the hell, right?
Right. Yeah.
Now, I know in change, you have to move. There are people who are showing up
Yeah.
late or we just,
Yeah.
there's also team members
Yeah.
that you lose your audience.
Yeah.
How do you manage that?
Yeah. It's,
And I think in leadership, that's incredibly hard to generate team, but bring the team along.
absolutely. It's, all of those challenges I've encountered, right? So they're, and I can only give you my specific, view on this. Steve and Covey, I skipped, there's like a bunch of Covey slides in here. That, I don't know if have you guys read The 7 Habits of Highly Effective People? So Stephen Covey has 7 principles. And one of them is little things, big things, right? So to do the big things, you got to pay attention to the little things, right? So if I was sending the letter, we had meetings about the letters and I knew pretty well what the story was before I sent the letter, right? Because my name was going on the letter and I owned it, right? And I'm like, I don't want to own this minutia of sending people letters about their on-time starts, but it was important, right? And so I had to do the little thing to ensure that things were correct. Even then, I made some mistakes, right? So I sent letters to people who were like, no, this is wrong. I was there, like I was doing something important, and I apologized. I said, look, I'm not going to get this all right. Here's what we're trying to do. I really appreciate your support if you agree with where we're trying to move the OR, right? So there was an element of, look, I'm gonna get this wrong. I've made a mistake here. Please forgive me, but also please join my team because we need to get this right. The other thing was we didn't send the letters unless the room went in late, right? So we gave the suggested arrival times, but they were only suggested, right? The trigger was like, did you go in after 7:40? And then what we asked them to do was to have a discussion as a team, right, in the room during the universal protocol. Like we asked them to add the delay type to the universal protocol and to have a discussion. And so when I would get the call after I had like pre-verified what the story was, I would say to the surgeon, I would say, well, did we have the discussion at the debrief as part of the universal protocol? And I started to find that 0 times had they had the discussion, people were uncomfortable having the discussion. And so that's something that we've continued to work on, right? It's like, how do we encourage, how do we bring down the barriers to communication between anesthesia, surgery, and nursing to just make this a regular part of what we do, right? Like there's no blame. There is nobody's a bad person because we went into the room late. We just need to identify a reason. And we don't really care if the reason was like you were stuck on 90 in a traffic jam or the patient showed up late or went to the wrong building. We're just identifying the issues so that we can make it better the next time. So I hope that answered your question.
Not to harp on the letters.
Yeah.
I was wondering, when you implemented this, was there any discussion on doing the reverse? Instead of giving letters when people are late, giving letters when people are always on time? You
Yeah.
know, if someone hits 95% of their starts on time,
Yeah.
giving them a letter. And doing that not just for the surgeons, but the rooms and the anesthesia, just to kind of, if you just think about it, if you're only getting a letter from your chair when you're late.
Mhm.
And that's the only attention you're getting from your chair,
Yeah.
that's not a very good,
Yeah,
you know.
it's like,
That's
it's
a-
low engagement scores is what it is.
Yeah, right, so if you reverse it and you give people letters for doing a good job.
Yeah.
Even though it's just the opposite, like,
Yeah.
you know, I think that might be your step from going from 70 now to 90.
Yeah, that's a great idea. What we did was we published, just because like, it was a lot of work to do the letters, period, but, we published the rooms that went in on time on these big, like, electronic whiteboards in the OR. So it's a little bit of what you're saying, but not quite as effective as a letter, but something that I will consider after hearing your suggestion.
Great talk, Dr.
Yeah.
To ask questions, we run to the OR so I don't get a second. By the, one of your beginning slide.
Yeah,
That, you know, most of the major healthcare institutions
Yeah.
are in the red.
yeah,
Providence is even in the negative in terms of revenue.
yeah,
So if you look at healthcare economics, I just switched topic a little.
yeah, yeah,
You know, physician reimbursement is just keeping with inflation.
yeah,
If you look at the healthcare expenditure, it's going way up and it
Yeah.
correlates with administrations, in healthcare.
mm,
So inefficiency adds cost.
yeah.
So what are your thoughts on that? And perhaps AI can make some of this inefficiency better in the healthcare ecosystem?
Yeah. That's a complicated answer, but, there's been a lot of movement recently on vertically integrated healthcare systems. So you guys know what that is? Right, so a vertically integrated healthcare system is a system that owns the hospital, they own the insurance company, they own the pharmacy, they own everything from top to bottom. Right? And so they say, well, to payers, or to the government, they can do this too. They can say, well, look, we're probably not gonna make a margin on clinical operations, right? But we'll make it on the insurance company, right? And so that's what a lot of the for-profit systems do, right? Or that we're gonna make it on the pharmacy. The non-for-profits are not, we were not quite so nimble. And so that's why we're kind of stuck in this situation of rising costs, with less revenue than we used to get. I think that's the importance of, you know, things like Steve has been involved with, so the PAC, and really advocating to Congress for better payment. And to really incentivize us to be more efficient, right? Like when I talk to my folks and they're like, I need to do a robotic cholecystectomy. And I'm like, well, there's a cost to that, right? For you doing 8 robotic cholecystectomies. That I'm not sure we've been great about policing as a medical community, right? Like if we were in private practice, right? We probably would make different choices, right? And so that's what I'm starting to talk to my faculty about is like, okay, there's these big external factors, right? There's some vertically integrated companies that are changing the way payment is done. We can't necessarily control that. There's PAC, so how we advocate to Congress for Medicare payments, that's one end. But what I also talked about to my faculty about is like, look, if you ran your own private practice and you were in this nonprofit system, how would you run your business? How would you make the hard decisions over what cases get done on a more expensive system, right? Versus the way that we've traditionally done stuff. And then the fourth item, which you alluded to, which is very tricky to get into, and I don't know if I want to wade into that this morning, is the size of the administrative structure that we have, right? Because you can see it even at our level, all of my faculty need their own individual PA, right? And it grows from there, right? Like we hire administrators and they have to hire an administrator and it gets bigger and bigger and bigger. And it's not clear that we're always deriving benefit from such a huge administrative structure. Now you might argue, well, maybe that has something to do with the federal government and all the requirements and all the paperwork and all this stuff that we have to do. And so you need people to do that, but it's something we need to think about as we think about costs, right? Because it all costs something, like me taking time to fill out, you know, a pre-approval or pre-search, right? It costs money and time. Yes, sir.
After all, I was struck by your comments on building trust.
Yeah.
Our residency recently, last few years, is implemented a leadership training program for
Yeah.
people at 85.
That's awesome.
And it's been really great, but one of the challenges we identify is that we're always working with different teams. We don't necessarily know who's routing one desk in the day. You mentioned, surgeons walk into a room with the team they're not familiar with. How do you approach building trust in those settings?
I don't know. I don't really know. But I bet you if somebody focuses on that, right, that's gonna be a topic that's gonna be really impactful in the future, right? And because it happens in other industries, right? So I talk to some pilots and stuff, and I'm like, well, do you fly with the same group of people every day? And they're like, no. Right? Like I might show up to the airport, my co-pilot is from Omaha, right? And the flight attendants are from somewhere else, and they figure out a way to make the day pleasant and efficient. Um, and to some extent, I've been able to do that personally, right? But how do we study that, right? What are like the general principles and core tenets that you use to do that, right? I do it unconsciously, right? And sometimes I fail, right? Sometimes I do, like somebody leaves and they're like, Jason's a jerk, right? But those of us that do it well, how do we do that? What are the unconscious moves that we make, and how do we make those conscious and identified so that other people can use that example? So I don't know the answer to your question, but it needs to be studied because I don't see this. I don't see us going back to an era where like Dave Schatz had the same scrub nurse for 40 years, right? And she knew like if he went like this, that he needed the medicine bomb, right? Like that does not seem like a reality that we're going to see ever again in American healthcare, right?
A lot of challenges to figure out here. Go upstairs or